Our first topic for today is autoimmune hepatitis. Some conditions which can cause hepatitis, and the first of them is autoimmune hepatitis. When to suspect autoimmune hepatitis, if a middle-aged female present to you with abnormal LFTs and secondary amenorrhea, a young or middle-aged female present to you with abnormal LFTs and secondary amenorrhea, you will think of autoimmune hepatitis. Every hepatitis will have raised ALT, alanine transaminase, aspartate transaminase, and bilirubin. So a young or middle-aged female with abnormal LFTs and secondary amenorrhea, you will suspect autoimmune hepatitis. And her lab values, her LFTs will be deranged, ALT and AST will be raised, and alkaline phosphatase or ALP will also be mildly raised. The other hint for autoimmune hepatitis is the presence of any other autoimmune disease such as vitiligo, Addison disease, or thyroid disease or diabetes type 1. Remember that autoimmune hepatitis can lead to liver cirrhosis. So whenever there is a liver cirrhosis, develops, it means scarring in the liver parenchyma develops, which leads to shrinkage of liver. And whenever a liver is shrunken, it will lead to increased pressure in the portal circulation, which will result in portal hypertension. And because of portal hypertension, the fluid will come out of the circulatory system and will result in accumulation of fluid in the peritoneal cavity, which is also known as ascites. So one sign of liver cirrhosis or liver disease is ascites. And as we all know that there is anastomosis between portal circulation and systemic circulation. So if there is portal hypertension due to liver cirrhosis, it will automatically lead an increase in the pressure in systemic circulation or systemic veins, which will result in the formation of varices, especially in the esophagus, and the rupture of varices can cause hematemesis. So anything that causes liver cirrhosis will result in ascites, hematemesis, jaundice, because liver parenchyma is damaged and there will be no conjugation, so bilirubin level will increase, which will result in jaundice. Hepatomegaly, initially there will be hepatomegaly, but in the long run, liver cirrhosis will cause sunken liver or shrunken liver. And because the pressure in the systemic circulation is also high, therefore it will result in the dilation of the blood vessels in different areas of the body, such as chest or abdominal wall, which are called spider nevi. So spider nevi are basically dilated blood vessels which are present in the liver disease. So one cause of liver disease is autoimmune hepatitis. The hint towards autoimmune hepatitis is a middle-aged female. Remember that autoimmune diseases are common in female. So a middle-aged female with secondary amenorrhea and abdominal LFTs, you will think of autoimmune hepatitis. The second cause of hepatitis or liver cirrhosis in UK is alcoholic liver disease. Alcohol can also cause hepatitis and liver cirrhosis and will cause signs of liver diseases. What are the signs of liver disease or cirrhosis? The sign of liver disease or cirrhosis is ascites, hematemesis, jaundice, spider nevi. Remember that normally in hepatitis, such as autoimmune hepatitis, ALT is raised more than AST. But in alcoholic liver disease, the ratio of AST and ALT is reversed. AST is both AST and ALT are elevated. However, AST is more elevated than ALT. So if AST is more elevated than ALT, then it is most probably due to excessive alcohol consumption. The liver disease is most probably due to excessive alcohol consumption. One other enzymatic marker which is raised in hepatitis or in liver disease is gamma glutamyl transferase. GGT is also increased in liver disease. ALT, AST, and GGT, three of them are raised in liver disease. Liver disease or autoimmune hepatitis or alcoholic liver disease, both of them can cause liver cirrhosis, and liver cirrhosis will manifest as ascites, hematemesis, jaundice, and spider nevi. Management of alcohol liver disease is to stop alcohol, and the only definitive treatment for liver cirrhosis is liver transplant. In case of alcoholic liver disease, liver transplant can be done 6 months after alcohol abstinence. So two conditions that can cause liver disease or liver cirrhosis, autoimmune hepatitis and alcoholic liver disease. Now we are going to discuss some condition which affect the liver in pregnancy. The first of them is HELLP syndrome, and the second one is acute fatty liver of pregnancy. What is HELLP syndrome? HELP is basically an abbreviation of hemolytic anemia, H for hemolytic anemia, E for elevated, L for liver enzyme. So hemolytic anemia plus elevated liver enzyme such as AST and ALT plus LP stand for low platelets. So a triad of these symptoms along with abdominal pain, then your diagnosis will be HELP syndrome. HELP syndrome is basically a complication of pregnancy. So if a pregnant woman present to you with elevated liver enzyme, you will have to look at the other lab values. If in the labs anemia is mentioned and low platelet counts are mentioned, then most probably the abnormal LFTs in pregnancy in this patient will be due to HELP syndrome. The second one is acute fatty liver of pregnancy. The cause of HELP syndrome is microvascular endothelial activation. Microvessels, microvascular endothelial cell activation result in hemolysis and low platelet count. and abnormal LFTs. What is acute fatty liver of pregnancy? In acute fatty liver of pregnancy, basically there is a problem in the mitochondria. In mitochondria, beta oxidation of fatty acid occurs. So the enzymes involved in the beta oxidation of fatty acids, they are defective due to an unknown mechanism, which can result in an acute fatty liver of pregnancy during pregnancy. Acute fatty liver of pregnancy usually third trimester of pregnancy or immediately after birth. So acute fatty liver of pregnancy, the findings will be abnormal LFTs. In HELLP syndrome, there was hemolysis, while in acute fatty liver of pregnancy, there is no hemolysis, just abnormal LFTs or elevated LFTs, low platelets, plus decreased glucose, plus increased ammonia. Remember that whenever there is a problem with the liver, whenever there is a liver failure, we all know that the urea cycle occurs in the liver. In the liver, ammonia is converted into urea, which is excreted through kidneys. So if there's problem in the liver or if there's liver failure, it will result in increase in the ammonia concentration. So if female present to you with abnormal LFTs in pregnancy, you need to rule out two conditions. One is HELLP syndrome and other is acute fatty liver of pregnancy. If there is hemolysis and low platelet along with abnormal LFTs, then it is HELLP syndrome. And if there is hypoglycemia or hyperammonemia along with vomiting and nausea, then it is acute fatty liver of pregnancy. So causes of abnormal LFT in general is autoimmune hepatitis and alcohol liver disease. While causes of abnormal LFTs during pregnancy are HELLP syndrome and acute fatty liver of pregnancy. Acute fatty liver of pregnancy usually occur after 30 weeks of gestation or immediately after delivery. So up till now, is it clear to everyone? Is there any question anyone want to ask? In acute fatty liver, DIC can occur due to endothelial cell activation. So whenever there is endothelial cell activation, whenever endothelial cells are activated, then what will happen? The activated endothelial cell will mobilize the platelets and it can also mobilize the clotting factors, which can result in disseminated intravascular coagulation throughout the body. if someone want to ask a question, he or she can mute himself and unmute himself and ask the question so that question can be recorded in the lectures as well, because I'm going to upload it on YouTube. So any of your queries you can ask on mic by unmuting yourself. Okay, now key number 12 is intermittent diarrhea plus abdominal bloating plus fatigue. What is your diagnosis?
Celiac disease.
Yes, intermittent diarrhea, bloating is a feature of celiac disease. And why there is fatigue in celiac disease? Why is there fatigue? What is the reason of fatigue in celiac disease?
Anemia.
Anyone?
Anemia,
Yes.
and also
Yes. Anemia.
loss of all the nutrients like B12
Yes.
and
Yes, that's right. B12, iron. What is the most common anemia in celiac disease?
it's iron deficiency anemia. Sorry,
Yes, that's right.
macrocytic and
Iron deficiency anemia is the most common.
Mhm.
Macrocytic anemia is the second most common. Iron deficiency anemia is most common anemia in celiac disease, followed by folic acid deficiency and B12 deficiency anemia. Our next topic is acute cholecystitis. Cholecystitis is basically inflammation of the gallbladder. Gallbladder is present in the right upper quadrant of the body. So whenever there's inflammation in the gallbladder, inflammation is mostly due to infection or gallstones. And gallbladder is present in the right upper quadrant. So inflammation of the gallbladder will result in pain in the right upper quadrant of the body, along with fever, nausea and vomiting, plus positive Murphy sign. Positive Murphy's sign. What is positive Murphy's sign? When you palpate, when you press in the right upper quadrant in the mid clavicular line, the patient will feel pain or he will stop breathing for a moment. This is positive Murphy's sign. So what are the features which will point towards acute cholecystitis? Pain in the right upper quadrant, fever plus positive Murphy sign. Acute cholecystitis. And also there can be nausea and vomiting as well. What will be the lab findings in acute cholecystitis, as it's an infection? So WBC will be increased and FTs will also be mildly deranged. 90% of the acute cholecystitis cases are due to blockage of cystic duct by a gallstone. So the risk factor for acute cholecystitis includes, remember that 5Fs, 5F syndrome. Cholecystitis is also called 5F syndrome because it occurs most commonly in a females, fatty 40, fertile females. Cholecystitis is common in fair, fat female and fertile females who are over 40 years of age. So in Plab 1 exam, remember that don't confuse cholecystitis with ascending cholangitis. Both of them are different. For cholecystitis, to mark a diagnosis of cholecystitis, first you need to remember the risk factors. If a female in her 40s and he's obese, she's obese, present to you with right upper quadrant pain and positive Murphy sign and nausea and vomiting, then it is most probably acute cholecystitis. While in ascending cholangitis, there is a Charcot triad, a triad of three symptoms. Right upper quadrant pain, this is common to acute cholecystitis, fever, and the third one, which is going to differentiate it from acute cholecystitis, is jaundice. Acute cholecystitis can also cause jaundice rarely, but the jaundice caused by acute cholecystitis is very mild, while the jaundice in ascending cholangitis is very marked jaundice. So if a patient presents to you with right upper quadrant pain, fever, and jaundice, then this completes Charcot's triad, and you will mark it as ascending cholangitis. And if someone presents to you with right upper quadrant pain, fever, nausea, and vomiting, along with positive Murphy sign, then it is cholecystitis. The risk factors for cholecystitis is females who are above 40 and are obese, while the risk factor for ascending cholangitis is history of gallstones. What is the management of acute cholecystitis? Investigation. Initial investigation will include WBC count will be raised, LFTs will be mildly deranged, and on ultrasound abdomen there will be gallstones and thick walled shrunken gallbladder. The treatment include nothing per mouth, IV analgesics for the pain, IV fluid, IV antibiotics, and laparoscopic cholecystectomy within 1 week of diagnosis. So the initial is antibiotics, fluid, analgesics, and the definitive treatment according to NICE guidelines is laparoscopic cholecystectomy within 1 week of diagnosis. But if someone present to you with asymptomatic gallstones, incidental finding on ultrasound, if someone present to you with asymptomatic gallstones, then there is no need of any treatment. You will only reassure the patient. So cholelithiasis, asymptomatic gallstones are called cholelithiasis. So cholelithiasis requires no treatment. While cholecystitis, there is inflammation due to stones. So the definitive treatment of cholecystitis is laparoscopic cholecystectomy within 1 week of diagnosis. Now, what will happen? What will you do if there is stone in the common bile duct? Stones in the common bile duct. Let me show you a diagram. This is liver. In liver, bile is formed. This is gallbladder. In gallbladder, bile is stored. Now, this is left hepatic duct and this is right hepatic duct. They both carry bile from liver into the common hepatic duct. They both combine to form a common hepatic duct. Common hepatic duct combine with cystic duct from gallbladder to form common bile duct. Remember that in gallbladder bile is stored while in liver bile is being synthesized. What will happen if there's a stone in the common bile duct? A stone in the common bile duct, even if it's asymptomatic, it needs laparoscopic cholecystectomy or ERCP. ERCP, what is ERCP? ERCP is endoscopic retrograde pancreatocholangiography. So asymptomatic gallstones reassurance, symptomatic gallstones laparoscopic cholecystectomy within 1 week of diagnosis, and common bile duct stones either symptomatic or asymptomatic, they need treatment or laparoscopic cholecystectomy or ERCP. Up till this point, is it clear to everyone? Do anyone want to ask any question?
Yeah, it is clear so far, but why it's just like in a common bile duct? This is if the stone is impacted there, why do we have to do the cholecystectomy? I mean, what's the reason?
Because if there is a stone here, it will result in the blockage of flow of bile from the liver to small intestine or second part of duodenum. And the
Okay.
increase in the pressure can result in the rupture of common bile duct, which can lead to peritonitis and sepsis.
Okay. Yeah.
So it can lead to life-threatening condition. So if there is incidental finding of common bile duct stone, then we need to operate it. Only reassurance is not gonna do anything. While in gallbladder, if the stone is lying here in the gallbladder and the patient is having no symptoms, then you do not need to do anything because the stone which is lying here is not gonna do any harm. Usually when the stone is impacted here in the neck of the gallbladder, it results in the inflammation of the gallbladder and causes cholecystitis. And the patient is feeling pain in the right hypochondrium. So that's why we need to operate for symptomatic gallstones. Because if the gallbladder is not removed, the patient's symptoms will remain persistent. Any other question?
Sir, can you please explain the difference between acute cholecystitis and ascending cholangitis?
In cholecystitis, acute cholecystitis, remember that history is important. If a female who is obese present to you, first of all, the risk factors. If in the scenario they mention that a female who is 45 years old present to you with right upper quadrant pain and fever, nausea and vomiting, then it is cholecystitis. In ascending cholangitis, there will be Charcot triad. What is Charcot triad? Right upper quadrant pain, fever, which is common to cholecystitis. But the third symptom, which is required for the diagnosis of ascending cholangitis, is jaundice. So if there's Charcot triad, such as fever, right upper quadrant pain, and jaundice, then it is ascending cholangitis. So someone with a history of gallstones present to you with right upper quadrant pain, fever, and jaundice, then it is ascending cholangitis. And someone, if middle-aged female who is obese present to you with right upper quadrant pain, fever, nausea, vomiting, then it is cholecystitis. Cholecystitis can cause jaundice, but it is jaundice. So for the diagnosis of cholecystitis, jaundice is not required. But if along with right upper quadrant pain and fever, there's jaundice, marked jaundice. Is it clear?
Yes, sir. No.
Now, in yesterday lecture, we discussed about the causes of dysphagia. Can someone revise the causes of dysphagia that we discussed tomorrow or yesterday? The causes of dysphagia. Yes, please.
Sir, it can be achalasia.
Yes, eclasia.
In achalasia, there is dysphagia for both solids and liquids simultaneously. And
Yes.
there can be a mass, but we can differentiate between this is with the mass. There is progressive like dysphagia for first for solids and then for liquids. While it's obstructing cholecystitis.
Yes. So one cause is eclasia, the other cause is esophageal cancer.
Yes, sir.
Any other
I think
cause other than these two?
we have discussed only these two yesterday.
There was one other cause as well. If someone else,
It's a pharyngeal pouch, Zinger
yes,
diverticulum.
it's yes, Zinger diverticulum or pharyngeal pouch. So we discuss those three types of dysphagia, causes of dysphagia due to problem in the esophagus. Now there's a fourth one, which is called Plummer-Wilson syndrome or Patterson-Kelly syndrome. If someone present to you with a triad of dysphagia, iron deficiency anemia, plus esophageal web, then your diagnosis will be Plummer-Wilson syndrome. In Plummer-Wilson syndrome, in esophagus, there is a web of mucosa which causes dysphagia. So the triad for Plummer-Vinson syndrome or Patterson-Kelly syndrome is dysphagia, iron deficiency anemia, and esophageal web. And the treatment for Plummer-Vinson syndrome is web dilatation and iron supplements because there's iron deficiency anemia and because the web is causing a dysphagia. So web dilatation and iron supplement is the treatment for Plummer-Wilson syndrome. Now, this was the fourth cause of dysphagia: eclasia, esophageal cancer, pharyngeal pouch, and now Plummer-Wilson syndrome. Now, the fifth cause of dysphagia, we'll discuss that, but let's first discuss an example. Can anyone read this example scenario at the bottom of the page?
An elderly patient presents with history of persistent dysphagia to both solids and liquids, no weight loss, no regurgitation. He takes alendronate for his osteoporosis. What is diagnosis?
So a patient with persistent dysphagia for both solids and liquids. What is the diagnosis?
Achalasia?
Yes, up to this point, a patient who is having dysphagia to solids and liquids, Up to this point, it's eclesia. But what were the other point for the diagnosis of eclesia?
Alginis.
What were the other symptoms?
So there might be esophageal.
There might be
Esophageal structure. Structure of the esophagus.
yes, it can be stricture of esophagus. But first tell me, along with dysphagia for both solids and liquid, what were the other diagnostic points for eclesia?
No weight loss. No so that is like there should be regurgitation in eclesia, but there's no regurgitation here.
Yes.
And for the esophageal cancer, there should be weight loss.
And also the age.
So they,
Yes, for
and the patient
eclesia,
is elderly.
yes, for eclesia, there should be regurgitation or aspiration pneumonia due to regurgitation, which is not the case in this scenario. So no weight loss rules out esophageal cancer, no regurgitation rules out the eclesia and pharyngeal pouch. Now he takes alendronate for his osteoporosis. What is the diagnosis? Remember that a patient with a history of GERD, gastroesophageal reflux disease, or a patient who is taking alendronate. Alendronate is basically a treatment in osteoporosis. Both gastroesophageal reflux disease and alendronate can result in the formation of stricture in the esophagus, scarring of the esophagus, and which will ultimately result in the formation of esophageal stricture. So the fifth cause of dysphagia is esophageal stricture. And as from this example, you can see that esophageal stricture will have dysphagia for both solids and liquids. But there will be no regurgitation because the esophagus is narrow due to stricture formation. The food will pass forward but slowly. So there will be dysphagia but no backflow of food. So if someone with a history of